Welcome, everybody. Thanks so much for joining us today for our second weekly Fireside chat on public health issues with two experts from Boston College, Nadia Abuelezam and Dr. Phil Landrigan. Thank you to them, and thank you to all of you for joining us. I wanted a quick word to let you know that we'll be recording today's session, so your questions will be recorded as well. And Boston College has asked that we allow it to be posted on the BC website so that it can be shared much more widely. And we're happy to do that as hosts. And I just wanted to let you know that it will be recorded as participants as well. We're calling this a fireside chat in reference to something deep in American history in a way. Back in the 1930s and 40s, the fireside chats were a series of evening radio addresses given by President Franklin Roosevelt between 1933 and 1944 during the Great Depression and early into World War II. And he used the radio as a direct means of communicating to citizens in order to quell rumors and explain his policies and communicate a sort of self-assured leadership amidst a time of great uncertainty. So we felt that this sort of historical reference was important to us, using what we have as new technology, the sort of distributed internet video conference, to reach out and share good information amidst all of the uncertainty that's out there with you, and to bring two amazing people and experts in the field to be our leaders in this conversation each week. We will be inviting additional experts as well here and there throughout the course of the semester, and we welcome your suggestions as to who those ought to be. I'll be turning it over to Drs. Abuelezam and Landrigan in just a moment. But before I start, I'd like to give an opportunity to two of my colleagues, Professor Ling Zhang and Professor David Mozina, who have been working on a really important project to help in a small but very important way to bring medical equipment here to hospitals in Boston. Ling, could you say a word about that? And we'll put a link in the chat for people who want to help follow up with that.
Thank you. Yeah, thank you so much, Eric, for giving me this opportunity. And I'd like to give my thanks to our specialists here. Remember last week I was asking our medical specialist whether or not we're doing the right thing, if or not we should do this thing, sending medical supplies from China to Boston. So to report back what we are doing here. So David's in another meeting, so he's not here. So I'm going to just say everything on behalf of him. So we started at a fundraiser on PayPal and also on Facebook to collect money in order to fund our very private, small-scale effort to buy medical supplies, PPE from China. And the effort, on the ground of China, was really arranged by my family. So they basically try to shop in the city from medical stores, try to establish connections with face mask manufacturers, and basically collect whatever they can find. And things should be supposed to be certified by Chinese government, not necessarily according to American standards. But at this moment, we just collect money, sending money over so they can buy things. Insofar, we've collected 10,000 US dollars here, so we're very happy. So today, our very first FedEx box, basically a box of medical goggles, have just arrived. So we have friends working for hospitals, so they will be taking the responsibility of delivering the box to the donation sites. So this is what we are doing. So I'm shouting out to you, not simply to say, well, donate to us, because we're very aware the small scale effort we're making is very limited. So I want to send out actually another information. Me and several activist friends in Hong Kong, in China, we are organizing to put together information of supplier manufacturers and shipping carriers in Asia. So if you know anyone who are in hospitals managing the purchasing department and have the intention to build up a direct connection to make big purchase from Asia, I have some information here. So that probably, by doing that, we can do things in terms of a scale. So that perhaps can be more meaningful. So reach out to me if you found this is meaningful. I'm in history department. link Zhang, I will send out my email to you all. So free to circulate all this to people that you know. Thank you, Erik.
Thanks so much, Lane. Could you, yeah, we'll fill 1 second. Could you also put your email address in the chat and
Sure.
the web link
Mm-hmm.
that you'd like to do? And Phil, yes? We need your mute off.
Right. So, Ling, that's wonderful work. Congratulations on it. That's great work. My one suggestion, having spent most of my life working in big hospitals, is you don't just want to send it to a place like the Mass General Hospital or the Brigham and Women's. It'd be very important that the packages you send from China be addressed to a specific person. Otherwise, they'll get lost and the equipment that you've worked so hard to gather will not be accessed.
Right. Thank you so much, Philip. If I can, yeah, if I may. So right now, I am the person to receive all the boxes. So I will look at the boxes to see if, you know, the packaging company has done anything to it. Are we getting everything? So that's what I'm doing on this part. But I think what you said is really important. Yeah.
If, in that case, since it'll be coming to you, I have children who are physicians at Children's Hospital, 2 of them. And
Yeah.
If you can get it to me, I can get it to them.
Great. I'll do that.
Okay.
Great. This is exactly the kind of community building and community efforts we're hoping to foster here. Thank you, Lang, for all of that extra work you've done, and to all the people who have already donated to that project. It's really great to see it take off. Let's turn to Nadia to start us off today with a brief update on what's happening locally, nationally, internationally, as you will, whichever you don't have to cover everything. And then we'll have a few opening remarks by Phil as well around public health questions, and then we'll open up as usual for the bulk of our time for questions and answers. Go ahead, Nadia.
Well, thank you, Erik, and it's a pleasure to be here with everyone. I hope everyone is feeling well and staying healthy. I miss all the students. I see a lot of the students on, and it's really wonderful to see you here. And I hope you know that we do miss you. It's very strange to be lecturing on Panapto or Zoom. I'm going to start off with some very brief remarks about where we are in this epidemic. So I've put up the Johns Hopkins Data Hub that Phil had referenced last week. And I just wanted to point out a few things that may be interesting to some of you. So first of all, we've now exceeded 800,000 cases globally, which is really something to think about when you think about that number. And you can see that the total deaths globally are around 39,000 deaths. Italy has sort of topped the charts in terms of the total number of deaths. I just wanted to look briefly at the US's numbers. The US, as many of you have heard in the news now, has the largest total number of confirmed cases. And so if we zoom in on the US, we see the US has 3,000 deaths. And I just wanted to take you to, and over 165,000 confirmed cases. Now, I just wanted to point out something, a discussion that's happening right now in the public health and the epidemiology community, which is it's really important when we're talking about this data that we're using the words confirmed cases or known cases, because it's very clear to us that there are many more cases out there that we simply have not tested, that we are not aware of. And so it's really important when we're using these maps or using these figures that we're using the term confirmed. The New York Times has this fantastic graphic. I've shrunk it down a little bit because it wouldn't fit on the screen otherwise, but it gives you a sense of where we're seeing the largest number of cases being reported. And obviously, if you're looking at this chart, New York is above and beyond any other part of the country. You'll also notice other burgeoning epidemics. Specifically, we're quite worried about Miami in the south. We're really worried about Michigan and Detroit as well in the Midwest, and Los Angeles is another point of concern that's coming up as well. So thinking about these, oh, of course, New Orleans has been in the news quite a bit lately. The number of new cases being diagnosed is one of the highest in the country in New Orleans as well. And for those of you who sort of have followed the news about other types of epidemics, including the opioid epidemic, this part of the country has been hit by a number of natural disasters. And so there's a large likelihood that there are huge inequities in the spread of this disease and also in the diagnosis of this disease overall. So needless to say, no state has been spared. Unfortunately, all states are now reporting cases. And there has been a lot of discussion about when our epidemic curve is going to subside. So if I go back to this chart and we're looking at the US number of confirmed cases, what you'll notice about this graph down here with the yellow line is that we aren't yet seeing that curve that we would expect to see if we would expect the epidemic to be leveling out. So unfortunately, we are still in this exponential growth phase of the epidemic. I'm just going to show you, and I know there's been a lot of controversy on China's numbers, whether or not China has been reporting accurately on their numbers, but I just want to show you their curve, just so you can get a sense of the difference in the shape, right? So the shape of China's curve suggests that there was exponential growth initially, but there was a turn in the epidemic peak, and we've now seen a flattening. Again, there's been a lot of discussion about whether or not these numbers are accurate, but regardless of whether or not they're giving us the full picture, I think the point that I'm trying to make here is the shape of the curve differs than the shape of the US curve, which we're still in this exponential growth phase. I wanted to also point out another website where I've been looking at a lot of data. This website is called ourworldindata.org. I'd highly recommend going there. They're trying to keep a lot of these charts up to date. And this graph essentially gives you the days since the 100th total confirmed case in a particular country. And on the y-axis, we're looking at the total number of confirmed cases. And again, I'd like us to focus on the United States curve, which hopefully you can see highlighted there. And what this is telling us is that the number of total confirmed cases is doubling between every 2 and 3 days. So we're still very much in this exponential part of the curve with regard to new cases. The good news is that we're testing more. I don't know if you guys have followed the news about Massachusetts in particular, but the Broad Institute has now built up their capabilities such that they can actually process upwards of 3,000 tests per day, which is phenomenal. And it's hopefully going to help our particular region in the Northeast to get ahead of the testing curve. So there's not going to be the delays that we've seen initially in returning tests. There's another figure that I wanted to show. This is related to the number of confirmed deaths. And you can see that in the United States, the number of confirmed deaths is doubling every 4 days. And so while our number of new cases is doubling every 2 to 3 days, the number of deaths is doubling every 4 days. And you can see how this compares to other countries. Granted, other countries are at different parts of their epidemic curve. So that's a very, very quick and dirty description of where we are now in the epidemic. But I hope it gives you a sense of for the total burden and what we might expect to see in the coming weeks. And I'm happy to answer questions about projections or other issues that people have questions about. So thanks.
Great, thanks very much, Nadia. Phil?
All right, thank you, Nadia. That's so clear. And I think the point you made that these are reported cases, known cases, confirmed cases is very important, that the true number could be as much as 5 or 10 times greater. I don't think anybody knows because the proper studies yet to know what percentage of people have only mild or inconsequential infection, and those studies have just not been done. So let's talk about the public health response to these data. The first point is that even though we recognize full well, people in the public health community recognize full well that these data are imperfect, for all the reasons that Nadia spoke to. Nonetheless, they paint a picture that is sufficiently well filled in that it can guide action. In other words, people don't need to sit around and wait for more data here before they can act. More data are obviously better. More data will enable the action to be more precisely calibrated to the need, but there's enough information there to act now and to demand that the action be quick. I think it's very interesting within the United States to look at how it's playing out, how the response is playing out. And I frame this in the context of a phrase that I learned a long time ago in political science, that the 50 states of the United States are the laboratories of democracy. The states are places where experiments can be tried out. If they work, they succeed. If they don't, they're quickly shelved. And states can often move a lot more rapidly than the national government because the population base is smaller, the number of decision makers is fewer, and things can be done quickly. I think we all have to take a look at New York State and specifically at Governor Andrew Cuomo in New York. Cuomo has been doing these very matter-of-fact, very blunt, pretty much daily briefings now for the past week or 10 days where he's presenting probably the most accurate, up-to-date information by any elected official in the country about what's going on in the country. It's interesting that the national leadership, after having disputed the New York data for a few days, and tried to make it go away, have now pretty much lined up behind New York, and as national leaders tend to do, taking credit for it. But that's another story not to be discussed here. But what New York is doing, and I stay in close touch with things there since I lived and worked there for so many years, is that they've really imposed very strict limitation on interpersonal contact, on movement of people out of the home, on gathering places like bars, restaurants, public meetings, and basically all of that is shut down, as it pretty much is in Boston. But I think it's gone even farther in New York. By contrast, unfortunately, there are parts of the country that still have not fully come to accept the threat of the epidemic. I saw something on TV a day or two ago where some large mega churches in the South were having large gatherings of their congregations, and the pastors were encouraging people to hug and to kiss, which will certainly accelerate the spread of the disease. All you need is one person in a group like that, and the R of 2 that Nadia has been talking about in that kind of a circumstance could become an R of 10. 2 is only an average. So that's how it's playing out. I think in terms of personal behavior, we all need to be patient. We need to be steady. We have to recognize that this thing is going to be with us for a while. I've seen 2 rather authoritative projections in the last couple of days about when this epidemic is going to peak in the United States. Dr. Anthony Fauci, whose name I think is familiar to everyone from the National Institutes of Health, and his colleague, Dr. Deborah Birx, have been talking about a peak date of April 21, so that's a good 3 weeks from now. Another website you might want to look at is sponsored by a group called the Institute for Health Metrics and Evaluation, IHME, and their website is simply ihme.org. They're a big public health data shop at the University of Washington in Seattle, supported by the Gates Foundation, and they have been doing some very elegant modeling. They have done a model where they correlate the projected number of cases with the number of acute care beds that are available in hospitals, city by city, state by state. And they've also done projections of when they think the thing is going to peak. And they're saying about the 15th or the 18th of April. So there we have 2 authoritative analysts, both predicting the mid to late April as the peak date. Of course, that's That's a national average. Like any average, there's going to be variation around the average. New York is probably going to peak sooner than other places. Massachusetts not far behind. Places in the Midwest and South several days to several weeks later as the epidemic rolls through. And the same thing is happening, of course, around the world. The epidemic is hitting different countries at different points in time. Some countries are much more globally interconnected than others. Countries in the global South don't have as much intercontinental travel as the economically developed countries in North America, Asia, and Europe. So the epidemic is reaching some of the sub-Saharan African countries, some of the South American countries only now. But once it gets into those countries where public health systems are weak, infrastructure is not well developed, it's going to take a very harsh toll. And of course, we know already from experience in the economically developed countries that the mortality rate for this disease is higher in people that have underlying diseases. And I suspect that in places in the global South where 10, 20, 30% of kids are undernourished, have either protein, calorie malnutrition, or are lacking in micronutrients, that the death toll could be a lot higher than it is in the generally well-nourished population in this country. So going forward, stay patient, understand that this thing is going to be a marathon and not a sprint. Don't relax your guard. I think at a very minimum, at an absolute minimum, we're looking at 4 to 6 weeks. If this thing peaks somewhere between the 15th and the 20th of April, then the downslope is not going to arrive much before the end of May or the beginning of June, in my opinion. That could change. Facts on the ground have changed our opinion on this thing before, but we have a lot more data now on which to base our projections. And so the range of error is narrower than it was even a few weeks ago. So Erik, I think I'll stop here and, like Nadia, be available for questions.
Okay, thanks so much, Phil. To ask questions, you're welcome. People who are in the audience here are welcome to type into the chat box. You should also have an option to raise your hand down at the bottom of the Zoom box. I don't have the same option as a host, but we can call on you by video to ask a question as well. We've left this open for video questions to help foster community. So feel free to sort of raise your digital hand as well. Let me ask one quick question, and then we had a typed question from Zara for everyone as well. My quick question was, have we learned anything in the past week? I mean, it's crazy that we're talking about a 1 week timetable now instead of a year or semester, but have we learned anything in the past week about acquired immunity such that we might know something about whether a peak in one place that, like Phil just mentioned, in the United States might simply be the first of many ping-ponged cycles of peaks that come afterwards if we're not rendered immune, or if too small of a population acquires it and in the process?
So my understanding, my reading right now is that we don't have any additional information than what we had last week. Again, we're still assuming that because this is a virus, there will be some protection, and hopefully that protection will last for a few months. But even if that protection, again, lasts for a few months, we still could be seeing a second peak in the fall. And so it's just important to remember that immunity will help us now in terms of figuring out how to target interventions, but it's not going to solve all of our problems in the future.
Yeah, I would second that and expand it upon it a bit further, because really, Erik, you were asking two questions. You asked number
Right.
one, does this virus confer herd immunity? And I come down in the same place as Nadia on that, which is to say, I hope so, but we don't really have the data. Based on past experience with a lot of other viral infections, everything from measles to smallpox to yellow fever, there's pretty good reason to think that there'll be lasting immunity, but that's speculation, that's not data. The other question you are asking is what percentage of the population is going to be infected, or to put it another way around, are enough people going to have been infected and have developed antibodies so that there develops what's called herd immunity, a sufficient level of immunity in the population that keeps the disease from spreading. And for most infectious diseases like measles, you don't really get solid herd immunity unless you've got something like 95% of the population with antibodies. So I think that my guess is that there will remain significant pockets of people in this country after June or July who have not been exposed, who have no protection, and who are therefore going to be vulnerable if there are reintroductions in September, as Nadia suggests there might be. All the social distancing that we're doing now, we're being so conscientious, we're being diligent, is really good. It's keeping us from getting sick during the time of peak hospitalization, which is a good thing because then we don't become one more body piling into the emergency room during the day when everybody else gets sick. But the downside of social distancing and social isolation is that we don't have the chance to build up antibodies and we could get nailed later on.
I just also want to say that there's been a lot of discussion about herd immunity because that was originally the UK stance on this, is that we were going to do what we had to do to get to a point where we had herd immunity, which, you know, was met with a huge backlash from the public health community, because when we think about herd immunity, we actually usually think about it in terms of vaccination, right? We want to get to a maximum number of people vaccinated such that we have herd immunity, not a maximum number of people infected such that we have herd immunity. So I think we have to be careful when we use the phrase herd immunity, because traditionally it's been used to talk about vaccination. And while it's true that if a large enough number of people are infected, we could have protective antibodies, it's a matter of terminology right now in the public health sphere.
Okay, yeah, thank you.
In that connection, a number of people have asked me, and I'm sure some of the questions that are going to be asked today concern vaccines and treatments for this. So let me just say a word about that, and maybe short circuit a couple of the questions. So people need to understand it takes a long time to bring a vaccine to market and bring it to a point where it can be widely deployed in a population. The reason for that is that most of the vaccines that we work with are based on the virus that causes the disease. And they can either be inactivated vaccines where the virus is killed by a chemical like formaldehyde and then injected into people and it still has enough protein in it to stimulate antibodies. Or the other kind of vaccine more commonly used is what's called an attenuated vaccine, which means that the wild type virus, the wild coronavirus that causes COVID-2, is somehow manipulated in the laboratory so that it's still infectious, but not as pathogenic, doesn't have as much potential to cause disease as the wild type. The smallpox virus, the measles virus, the yellow fever virus, all of them, the polio virus, they're all live attenuated vaccine viruses. So that'll be the goal. But you have to understand that to attenuate a virus and then to ascertain with a high degree of certainty that it really is attenuated, that you're not going to put it into people and make them sick, requires a very carefully graduated series of field tests. First, the people in the lab that develop the vaccine typically inject it into themselves and make sure it doesn't kill them. And if they survive, then they try 10 of their closest friends, then 100 people, and only then does it go, do you do a trial of maybe 1,000 or 2,000 people. And all of that, each of those steps takes time. And I can't imagine a vaccine being available for COVID-19 in anything less than 6 months, and more realistically, not much before a year. So I may be wrong. I'd love to be wrong, but I think that that's probably the reality. Then with regard to treatment, I would not be surprised if some effective treatments for this infection come along sooner than that. There are a series of antiviral drugs on the market. They're used with great efficacy, as we all know, to treat HIV/AIDS. Tamiflu treats influenza. People in the pharmacology business have learned something about targeting viruses with drugs. I don't know if chloroquine, the antimalarial drug, is going to make any difference or not. There's been some talk about it, but I haven't seen much real data. But in any event, I know that clinical trials are already going on. And if even if the drugs that are being tested don't completely cure the disease, if they make people less sick, if they reduce the risk of severe illness and death, then that'll be good stuff. And in the best of all possible worlds, we might have information on effective treatments in 1 to 3 months. It might also take 6 to 12 months, but if we're lucky, sooner.
Great, thank you. Could one of the two of you answer Zara's first question about why the recovered cases in the US look so low compared to confirmed cases, and whether or not we have an estimate here about how long it takes to recover?
Just so I can start, and I also would like to address her second question about how long the virus lasts on surfaces. So regarding recovered cases, so there's a pipeline here, right? So first you have to have symptoms. Second, you have to have a test and get the test results. And then there needs to be some form of monitoring of you to see that you have actually recovered. And for people who are in the hospital, that process, if you're hospitalized, that process of detecting that you're recovered is very straightforward. Whereas if you're one of the cases that the Department of Public Health has sent home for self-quarantine, you now have to report back to the Department of Health about your recovery status. And that is a data collection point that takes time. There's someone that has to plug that back into the computer, right? So there could be actually a lot of data that's lost on the recovery end, especially because we're so concerned with the testing end of this. So I think some of this is a pipeline issue in terms of what types of data we're actually keeping track of over time and how well we're able to keep track of everything. The other part of this is a timeline issue, which is that we're expecting, and I've seen estimates of recovery anywhere from 7 days to 3 weeks. So this could really be a delay, right? In when you get confirmed to when you recover, we might actually see the number of recovered cases increase in the next few weeks. So this could be a lag in terms of the time for recovery. With regard to your second question, which you posed, which is research on how long the virus lasts on surfaces, there was a paper published in the New England Journal of Medicine last week that looked at how long the virus lasted on surfaces, but in a lab setting. And I want to make that very clear up front. This was sort of done in a very controlled environment. And their estimates were that the virus can last on in the air for up to 3 hours, on copper or metal for up to 4 hours, on cardboard for up to 24 hours, and on plastic and stainless steel anywhere from 2 to 3 days. Now, those numbers sound really scary, but I just want to emphasize that that was in a controlled lab setting. And so we would expect that those numbers may actually differ in real world settings due to temperature, humidity, all sorts of other factors. But you can assume that the virus does last on surfaces for a while, which is why we're advocating for you to wipe down surfaces. And the other thing that I'd recommend for those of you who are going grocery shopping, perhaps consider wiping down packages before you store them in your homes. These could be safe steps that you take to protect yourself.
Let's go to the question from Grace Alec. Grace, do you want to turn on your video to make the comment?
Hi, thank you, Dr. Landrigan and Dr. Abuelezam, for doing this. So I have two friends, both college athletes. One, tested positive and is at home with a cough. The other tested positive and is in an induced coma. And I don't think this is an isolated incident. There's so much variation in cases. Do we understand enough about the virus to know why things are looking so different for people, even, aside from existing conditions?
First, I'm very sorry to hear that. That's really horrible news, and I hope that there is a quick recovery. I'll let Phil take this one because it's a much more clinical question.
Yeah, well, we certainly know that some groups within the population are at higher risk than others. The fatality rate is substantially higher in the elderly than in younger people. It's substantially higher in people with underlying illness than people without illness. And so if you're old and you have heart disease, for example, you're at seriously elevated risk because you've got several factors going on. It's hard to know why two young college athletes, both presumably fit, both demonstrably young, should have such different outcomes. And I don't think anybody knows at this point. There's always the possibility that the person who got sick had an underlying illness that they didn't know about. That's one possibility. And the other possibility is just to say we don't know enough. And it's inexplicable. And the only good thing you can say here is that he or she is in a place where there is good medical care and there's the availability of 21st century technology like medically induced coma, which is it has a pretty good likelihood of getting them through it. And it's a kind of technology that will be totally non-existent in poor countries in the world. But I can't say any more than that.
Yeah, thank you. I'm very sorry to hear that, Grace. We have a question from Josh Rappaport asking about an update on Seattle, given that was our first locus in the U.S. How are things there, and what can the lessons we learn from where they are on their curve or in their experience related to New York and Boston?
I saw Josh's question lurking there. And I was just visiting the King County, Seattle website. The Johns Hopkins map tells you how many deaths in different parts of the USA, but it doesn't present curve data for the different parts of the country. But the Washington State Department of Health has a good website. They've always been one of the better state health departments. And what they're showing, if you scroll down on their website, is that over the last about 7 days, the curve appears to be tending downward. And I presume they've been doing good social distancing and everything. Seattle tends to be a well-run city where people are compliant. It's not New York, and things seem to be slowly getting better, but I think it's too soon to say anything definitive.
I think something that we might be able to glean from their experience is that many of our hospitals around the country could have shortages of beds and could have shortages of ventilators simply due to the number of people that we've seen hospitalized in Seattle. And I think this has been heard by public health officials. As you know, people are calling for an increase in the number of ventilators and PPE available to healthcare workers. So I think we've looked at Seattle as like the example of what happened first in terms of our ability to respond in a clinical setting. And hopefully other areas are learning those lessons and are doing what they can to get a proper equipment and updated PPE.
And I can also speak to that because I continue to get the daily feed from Mount Sinai Hospital in New York, where I used to work. And Mount Sinai is, as we speak, using a couple of very large lobby spaces that are in the hospital for overflow beds. And they're working with an organization called Samaritan's Purse. I don't know who they are, but Samaritan's Purse is working with Mount Sinai to build a huge tent hospital in Central Park, which is just Mount Sinai is on 5th Avenue facing Central Park. So this will be in Central Park, basically across the road from the hospital. And then the third resource that they've got down in New York City, some of you might have seen on TV, the Navy hospital ship, the USS Comfort, has come into New York Harbor, and that has something like 1,200 beds.
Great, thanks. We had a question from another person about the testing landscape today. Do we have updates about rapid tests and home tests, or whether everything needs to go to the laboratory? Nadia, you mentioned the Broad Institute having ramped up their capacity, but we also are reading about these finger prick tests and things. Can someone give an update on where that is?
Well, broadly speaking, the tests fall into two categories. You can take a blood sample, either from the vein or the fingertip, and measure a person for antibodies against the virus. And antibodies take a few days to form after the person is infected. So for the first few days of infection, the virus is running around in their bloodstream, but the antibodies haven't yet come up, and then the antibodies come up. So if you're measuring for antibodies, you'll miss early infection, but on the other hand, you'll be able to see who's immune. The most rapid test, if somebody is coughing and having other symptoms today and they want a rapid test, assuming that they can get access to one, is the nasal swab. And what the nasal swab does is it collects some droplets of the fluid in your nose. If you're infected with COVID-19, the nasal secretions are going to contain the virus. They take the swab that's gone into your nose, they run it to the lab, and they do PCR, pretty straightforward PCR testing, and they'll know within about 24 hours if you have the virus running around in your bloodstream.
I just want to clarify, we don't have an antibody test or serology test right now for this that's sort of being used widely. So we don't have that capability yet, but it's coming. And there's a lot of labs that are working on it, and we expect to have that in the coming weeks. And I think one part of your question was, are these rapid tests being done sort of at individual hospitals, or do they still have to be sent to a lab? And it was true that all of these samples had to be originally sent to the CDC National Laboratory. That is no longer true. So local labs are now able to process these tests. And that means that tests are being returned much more rapidly than they were before. Many of you have probably seen sort of the advertisements for new rapid tests where you can get your result in a matter of hours. And I think while the technology is there, I'm not sure that those have been ramped up and distributed widely yet, although I'm sure that that will happen in the coming weeks.
So also with home testing, there's always reliability issues.
Okay, and so not a cure-all in terms of constantly checking because there may be false positives or false negatives.
Yeah, but
and the ability to get a proper sample when you're thinking about a nasal swab is, you know, you're probably going to be uncomfortable trying to do that yourself.
Yes. Other questions from the audience? You can raise your digital hand or type in a question in the chat box if you have a question. I mean, I'm still wondering how it seems New York is doing on the catch-up. We hear the governor, as you mentioned, Phil, giving some pretty strong information about the expected shortfall in beds and equipment and things like that. How has that changed in the past week from the beginnings of this desperate call to where now you mentioned the extra hospital beds starting to roll in? Is the protective gear coming, and are we seeing a building or a more flattening of the level of anxiety over machines and healthy healthcare providers, et cetera?
Well, breaking that down, the case count is still going up. But the slope of the curve seems to have attenuated some. It was doubling every 2 days. Now they're saying it's doubling every 4 days. I think that there's a lot of anxiety, but I think the governor and Governor Cuomo has done for New York what President Roosevelt did for the United States 80 or 90 years ago. And he's done a marvelous job of building a sense of community, a sense of solidarity. I was in New York after 9/11, and I saw that sort of coming together at that time, and I think he's doing his best to rekindle that. New York has a structural problem having to do with the fact that the population density in the city is so high. Upstate, of course, is like New England, but New York City, the proximal parts of Long Island and New Jersey and Westchester County, which is just immediately north of the city, very, very densely populated communities, especially the apartment towers in New York, where you've got 30, 40, 50 stories, one on top of the other. And it's just awfully hard to practice effective social isolation in that circumstance. I mean, people still need to eat, they still need to get basic supplies, and how do you do that when everything is just so packed in. And I think that's one of the reasons that the virus has spread so fast there. But I think they're doing the best they can. From what I hear, personal protective equipment, PPE, is still insufficient. That people are being told to, after an 8-hour shift or a 10-hour shift, to take off their mask, to put it in a plastic bag so they can use it again tomorrow.
Okay, thanks. We have a question from Zara again about the NSAIDs, about ibuprofen, et cetera, as a potentially harmful way of treating headaches and body aches. Have there been more studies and any confirmation about that?
No, case reports only. But I think, you know, that doesn't mean I would blow them off. I think if you're aching and hurting badly from this infection, one strategy to minimize the toxicity of any one compound is to take Tylenol one time and then 6 or 8 hours later take ibuprofen and go back and forth, so that you're not overloading your body with a single manufactured chemical. But that's, you know, that's not science what I'm talking about there. That's just sort of, you know, the kind of thing that medical practitioners do when they're trying to spread out risk.
Okay, thank you very much. Other questions out in the audience, or something that from Nadia or Phil that we haven't yet covered that you want to, well, here's one more. How will the pandemic affect future physical interpersonal interactions, such as hugging?
I was just on another call where we were discussing this because I think there's a lot of fear right now that this is going to become the new normal, that we are going to have to stay away from people and not hug people. And you know, I can't imagine a world like that. I think that would be really sad. I think that we're going to have to deal with this for a little while longer. I think Phil said 4 to 6 weeks. I might say that that might also happen another time later in the spring or later in the summer as well. And so this may become our near new normal, but I don't think that this will become our normal forever. I expect that we'll be able to return to normal activities. But what I do hope people learn from this more than anything is that we really do need to be prepared for the next pandemic. And, you know, what we've learned is that as a country, we were not prepared. And I think, if anything, you know, funding should increase for public health programs, for the CDC. We need to make sure that we have enough supplies in order to protect ourselves, our healthcare workers, if this were to happen again. So I'm not worried about the social aspect. I think people will have no problem returning back to normal on that regard. But I do worry about whether or not we've learned enough to implement change for a future pandemic. Because for those of you who've taken our public health classes, this is likely going to happen much more often moving into the future. And that's due to things like climate change, due to things like globalization. So we need to be prepared in order to handle it better, hopefully, in case it happens again.
Has there been any, oh, go ahead, Phil, yeah.
Just to follow up on that, you know, there's a political axiom that that a crisis is too important to waste. I may not be saying it quite right. You're closer to these things than I am, Erik, but that political leaders need to take advantage of a crisis to bring about change. Now, I've read in the papers that some political leaders around the world are taking advantage of the crisis to make the wrong kind of change. The leader in Hungary, for example, has declared what amounts to a state of martial law, which gives him absolute power. Here in the United States, the EPA has decided to suspend all environmental regulation. So just at a time when we need clean air, industries will be given permission to put out as much pollutants as they want. But on the positive side, wise leaders could seize upon this crisis to really make some substantial and lasting improvements in public health in this country. Nadia already spoke about the need to rebuild the pandemic preparedness infrastructure, which, as I think we've talked about previously in these fireside chats, has been shredded in the 2 or 3 years before before this pandemic, and is a major reason why the thing got off to such a big start in the United States unwatched for so many weeks. But beyond that, you know, there are some huge structural problems with public health in the United States. The biggest one in my mind is that public health is basically a state and city level responsibility across this country, that there is no national public health agency with command and control authority. CDC can only come into a state if they're invited into a state or into a city, if they're invited. It would be so nice to, if the new Congress, which will be in place after January, because I don't have any hope for the current Congress, if the new Congress could actually rewrite the Public Health Act, which goes back many decades, and come up with something that's fit for the 21st century, that recognizes the realities that Nadia is talking about, the increasing rate of emergence of viral infections, climate change, globalization, et cetera.
Yeah, I think the experts in public health and students in public health, you know, have this obligation to, you know, stay focused and help the policy work that's done on this, as well as the practical, you know, communal social health aspect of it as well. And the rest of us who aren't health experts, you know, have an obligation to be thinking about the broader cultural, political, legal aspects of this, that, you know, in a similar way to 9/11, that immediately people felt something was different, and it was used for good and ill as a justification among Americans, especially, to, you know, securitize everything and to render every, you know, huge buckets of spending were moved from place A to place B. A crisis, like Phil mentioned, can be used to reflect on our values and our spending priorities, as well as our moral priorities. And it can be a very positive thing in the long term to prevent it again, but it can be misused as well. And I think for all of us as students and scholars and citizens, we have an obligation to pay attention about the language that's being used to describe this, languages of emergency, languages of expertise, languages of anti-expertise, you know, resistance to expertise, and things like that, and to be active citizens on this. It seems paradoxical when being active right now means staying at home, but we're gathering digitally and we'll be voting soon. We need to resist any effort to prevent voting or to restrict it and beyond what's necessary to be safe. And we need to continue the democratic process of bringing our own informed, you know, citizen ethic to bear on this question as well, or else it will be taken in different directions than might be best for everyone. I think we've seen that happen in lots of places as well. We just have a couple minutes left, and we have a few quick questions around sort of why the U.S. failed to act more quickly or was proactive, and a question about Boston's, in particular, Boston's PPE supplies. Why don't we chat about those briefly, and then we'll wrap up. Either of you want to take on either of those?
I think we've already spoken to the question of why why did the U.S. wait so long. It had to do with the fact that, well, put it bluntly, it was a failure of national leadership. That and the roots of that has to do with two events that have taken place over the past several years. Number one, the slashing of the budget for the CDC, so that the CDC simply did not have the staff and the resources to respond quickly. And then secondly, the abolition about a year ago, I guess, of the so-called Office of Pandemic Preparedness within the National Security Council. The National Security Council is a small agency of the administrative branch of the government that responds the executive branch that reports directly to the president. It's the National Security Advisor who heads that office, is responsible for advising the government on security threats, military, diplomatic, financial, and biomedical. And they basically abolished the biomedical eyes and ears of the president's office about a year ago, so that no information about this threat was coming into the top leadership. And had that information been coming in, I think the response could have been a lot different. The first cases occurred in China, we now know, in early to mid-December. There was some initial suppression reported yesterday in the New York Times about case reporting in Wuhan, in the city of Wuhan and in Hubei province, which slowed everything down by a couple of weeks. But still, the word was out in China by the last week in December, and most certainly by the first week in January, that there was an epidemic of an unknown coronavirus going on. They knew by, I think, the 5th or the 7th of January that it was a coronavirus. China CDC reported that. And US CDC and the National Security Council should have jumped on that immediately. There's a long history of pandemics coming out of the densely populated cities of East Asia. It's not a political statement, it's just that there's a lot of people over there, a lot of opportunity for spread. That's where influenza tends to arise every year or two. And public health people typically go on high alert when they see an epidemic ticking up in China, especially if it's a new virus. Didn't happen. It didn't happen because nobody was watching, nobody was listening, and precious time when we could have been manufacturing personal protective equipment, well, we could have been mobilizing people and resources, precious weeks were lost, and now we're behind the curve. And I think that accounts for the reason that the spread of disease has been so sharp in this country.
And I think the undertone of what Phil is talking about is really how politics can directly influence public health, right? The two are intertwined. You cannot talk about one without talking about the other. And so I think it's just important to remember that while, yes, the failures were in the public health community, some of the reasons for those failures originated politically. And so I think I just want to say that because we talk about this all the time in our public health coursework at BC, that public health is political and you can't separate the two when it comes down to it, unfortunately.
Right, and saying it's political is not to say it's partisan, but rather it's part of a process of governance and responsiveness to the citizens' needs. And right. Thank you both so much, and thank you all for joining us today. I hope next week, I think it would be interesting to take up a few questions around the Scandinavian situation that have posed some interesting differences around what these countries have pursued, and we'll also look around the world as well. This has been really helpful as always, and I want to thank all the participants who showed up today. Thank you to Ling and David for the work you're doing to bring medical supplies here to Boston hospitals, and thank you Nadia and Phil as always for taking part in this. We'll be back next week, and bring your questions and tell your friends, and we look forward to seeing you all then. Thanks so much.
Thanks much.
Thank you.
Bye-bye.